from there on, I have invited two guests just to give an international flavor to our meeting. The first is Dr. Nico Chauke, and the second guest is Dr. Kieran Magavi. So Dr. Chauke is just having a bit of trouble connecting for the moment, but he'll be here with us soon. So without further ado, I'm going to ask Dr. Kujoka to start his presentation. And then later on, when Dr. Chauke has managed to join us, I'll do the formal profiles of both the invited panelists. Dr. Kujoka, over to you.
Okay, thank you, Dr. Nube. Good morning to you all. My name is Dr. Kujoka. I've already been introduced. I'll be presenting on multiligamentous knee injuries, but mainly focusing on the anatomy, biomechanics, clinical presentation, and the relevant investigations that we are supposed to do when we come across these patients. Initially, I just prepared a presentation for everything, including the management, but I think I'll just present up to investigations and presented by Dr. Magavi. So our learning objectives are to describe the essential anatomy of the knee joint, to review the biomechanics of the knee, describe mechanism of injury to the knee, evaluate a patient with multiligamentous knee injury, and to be able to interpret the relevant investigations. And then the last part of the presentation will be done by Dr. Magavi. Knee injuries, multiligamentous injuries, are not very common injuries. They have an incidence of between 0.02 to 2% of all orthopedic injuries. And these are described as when you have more than two ligamentous groups of the knee being injured. And sometimes you may actually get a frank dislocation where you have 3 out of the 4 supporting ligaments having been injured. And the outcomes are poor compared to patients with isolated ligamentous injuries. Just a review of the anatomy. This is the knee is the largest joint in the body. It's a diarthrodal joint which allows 3 planes of motion. It allows rotation, translation, and there's also axial rotation. It is a joint which is relatively exposed in terms of soft tissue protection and coverage. And also the other important thing to note is its close proximity to the neurovascular bundles that are going to the leg and foot in the popliteal fossa, where they are very close to the joint and they are prone to be injured. And the other thing to note as well in terms of the neurovascular bundles is the relatively tethered anatomy of the popliteal artery between the adductor hiatus and the fibrous arc of the soleus muscle, which further predisposes it to injury when we get these multiligamentous knee injuries and knee dislocations. The stability of the joint mainly depends on the supporting ligaments. The bony structure does not offer much in terms of stability. And these ligaments can be divided into 4 groups with medial structures, lateral structures, and we also have the intracapsular, anterior and posterior cruciate ligaments giving us our stability. So the knee joint basically is divided into 2 joints with the patellofemoral joint being the smaller joint between the patella and the anterior proximal femur, and we have the tibial-femoral joint, which is the larger joint between the femoral condyles and the tibial plateau. The tibial plateaus are covered by the menisci. We have two, a lateral and a medial. These menisci serve to deepen the joint, protect the tibial plateau, and also they increase the stability of the joint to some extent. So I will start by describing the structures that we find on the medial side of the knee. Generally, the structures on the medial side of the knee are the primary restraints to valgus forces, so they prevent valgus angulation. The most important being the medial collateral ligament. This ligament is divided into two. There's a superficial medial collateral ligament, which arises above the medial, it's slightly above and posterior to the medial epicondyle, and it attaches on the medial proximal tibia. This one is the major restraint. It offers about 60 to about 70 resistance to valgus forces. And deep to it, we have the deep medial collateral ligament. This ligament basically is a thickening of the medial capsule, which attaches to the medial of the medial capsule, which attaches to the medial meniscus, and can be divided into a menisco-femoral and menisco-tibial component. And then the third part of the medial collateral ligament is the posterior oblique ligament, which essentially is almost a separate ligament on itself. So, and then posterior to that, we have the structures that are defined as the posteromedial corner. The structures of the posteromedial corner basically are structures that are found behind the posterior border of the superficial medial collateral ligament and the medial border of the posterior cruciate ligament. So these structures involve the posterior oblique ligament that was mentioned above, the oblique popliteal ligament, which is the primary restraint to hyperextension, and the posterior capsule, and also the semi-membranous muscle, which is its 5 tendinous expansions that attach to the different structures on the medial aspect of the knee. So this is just a diagram which is depicting the structures that we're talking about. This where my cursor is a superficial medial collateral ligament, and behind it is the posterior oblique ligament. Deep to the superficial medial collateral ligament is where we find the deep medial collateral ligament. We cannot see it in this picture. Then this is the semi-membranous muscle, and this other structure here is the medial head of the gastrocnemius. So on top of these structures above, there is the muscles of the pes anserinus, from proximal to distal. We have the sartorius, the gracilis, and the semitendinosus attaching on the anteromedial aspect of the proximal tibia. This arrangement is also important in the description of the so-called sternal lesion, where after you have an avulsion of the superficial medial collateral ligament, it actually goes above the pes, and that will prevent it from healing and getting back to its normal position. Then the lateral knee structures, the most important is the lateral collateral ligament, also called the fibular collateral ligament. It resists forces of up to 750 newtons of rotation. If it goes a bit posterior, it prevents bone impingement and increases the joint of motion. So essentially, flexion is actually limited by soft tissues in the tibial-femoral joint. This is just another a table which is showing the joint reaction forces in the patellofemoral joint with different activities. So you can see that with deep squatting, we have a very high joint reaction forces of up to 15,000 newtons, or approximately 20 times body weight, and about 850 with walking. So the pathophysiology of multiligamentous knee injuries, these basically would depend on the amount of energy that is involved in the injury, the direction of force, and the position of the limb. So these injuries can be very high energy injuries, as in motor vehicle crash injuries or pedestrian motor vehicle injuries. They can also be low energy injuries, as in contact sports or other sports that have been that are shown in the picture below. Then you have a special group of patients who get what are called ultra low energy injuries. So these are usually morbidly obese patients, and they are usually female. So these patients can come with multiligamentous knee injury after just a simple fall from a standing height. And the direction of forces, basically you can have any direction of force giving eventual injury to more than one ligamentous structures, from varus, valgus, hyperextension, hyperflexion, direct blows to the bone, rotation, and combinations. The other most important aspect of these injuries is the associated injuries. As we have alluded before in our introduction, the close proximity of this joint to the neurovascular structures in the popliteal fossa predisposes patients to get nerve injuries. More commonly, the common peroneal nerve is injured rather than the tibial nerve. And with vascular injuries of up to 50%, associated fractures are also common, and because sometimes these injuries are associated with high energy transfers, as in motor vehicle accidents, sometimes you can get head, chest, and abdominal trauma, which may be life-threatening. Compartment syndrome and open injuries can also be associated with these injuries. So the clinical presentation, usually the majority, if not all, of these patients who often present acutely to hospital, because these are quite serious and painful injuries, and the main complaint is pain. Sometimes there is a history of deformity, but you rarely get a patient coming with a frank knee dislocation. Most of these injuries, they will spontaneously reduce, or sometimes they are reduced by people who were around at the time of injury, or by the paramedics. So history is indispensable, where you actually have to understand the mechanism of injury, if ever there was any dislocation or any deformity, and the direction or position of the distal extremity in relation to the rest of the body. You may also want to ask about neurological symptoms in the foot, like altered or loss of sensation and power. So on examination, the first part and most important, especially in acute injuries, is inspection. So you have to look for a deformity, you have to look for bruises, open wounds, swelling, the color of the distal extremity itself, and sometimes there are specific signs like the dimple sign, which is illustrated in this image, the lower image on my screen. This is an injury that is associated with buttonholing of the medial femoral condyle, and usually it presents with an irreducible tibiofemoral dislocation. And then we move on to palpation. You check for tenderness, warmth, compare with other limb, or because sometimes vascular injuries are common, and you may find that a patient can actually come with a cold limb. Check the pulses, the sensation as well. The acute examination, in terms of actually determining the specific injuries, is less fruitful because these patients are often in a lot of pain, and it's usually almost impossible to move the limb. But sometimes these patients can then maybe come back maybe after 2 weeks or so, when pain is much less. These patients, in addition to what you do when your patient presents acutely, you can then also move on to do a specific tests for the knee ligaments. So these are some of the tests that you can do for your patients. For the collateral ligaments, you can do a varus stress test to test for collateral ligament and the posterolateral corner stability, and the valgus stress test for the medial collateral ligaments. For the anterior cruciate, there are several tests that you can do, including the Ligament test, which is the most sensitive. You could also do the anterior drawers test, but it's less sensitive than the Ligament test. And then the pivot shift test is used to test for anterolateral rotational instability. Then for the posterior cruciate ligament, there are also several tests that you can do to inspect for the posterior seg, where after you flex your hip and knee to 90 degrees, you actually see your tibia sagging on your femur with a concave deformity below the patella. The posterior drawers test can also be done. We can also do the dial test. This one will differentiate posterolateral corner injuries from posterior cruciate ligament injuries, or it can actually detect if you have a combination of both. Then we have the posterior medial corner. We can do the Slocum test, and for the menisci, you can do the McMurray test and the Applis test. These tests can also be done acutely in the acute patient under anesthesia, or sometimes more often you need to take your patients for theater. One of the most important things that you have to do is a vascular assessment for your patients, because these are limb-threatening injuries. Vascular injury is very common, and it's up to 50% of patients who present with vascular injury. And one thing to note is present pulses do not equal no injury to the popliteal vessels. Sometimes you may find that a patient will come with a warm perfused limb with actually present pulses, but this is because of the very good collateral blood supply to the distal leg. So a patient can actually present with a serious popliteal artery injury, but with present pulses. So for all patients with multiligamentous knee injury, it is mandatory to do a Doppler angle brachial index for all patients with a normal value between 0.9 to 1.3. If your angle brachial index is less than 0.9, this is a patient who warrants a further vascular imaging, like a duplex sonography, CT angiogram, or conventional angiography. But largely, more of our patients now are getting a CT angio. The conventional angiography, even though considered the gold standard, is now being replaced by the less invasive CT angio, which is all very good sensitivities and specificities in terms of determining vascular injuries. So there is also a group of patients who actually come with high signs of ischemia, a patient who presents with a cold, pulseless limb. These patients, some surgeons will argue there is no need for doing angiography because we know the location of the injury. So these patients can actually be taken immediately for exploration. This is just a flow diagram showing the routes that you can take in terms of vascular assessment. Then in terms of imaging, acutely, you can do the plain x-rays, AP lateral and oblique. Pre-reduction x-rays are controversial. Most surgeons do argue that there is no need to send a patient with a dislocation for imaging. You have to reduce it immediately. And some of the things to look for include the second sign, which is a sign of avulsion, anterolateral avulsion of the proximal tibia. as a result of it points towards anterior cruciate ligament. Then there is an acute sign, which is a fracture of the proximal of the fibular head. It's a sign which points towards injury to the lateral structures that attach on the fibular head. Then the other things are subluxation, joint space widening, rim fractures, periarticular fractures. These are just images showing this one is the second sign. Then this is an acute sign with a fracture of the fibular head on this diagram. Then there are stress views. These are done fluoroscopically under anesthesia and with side-to-side comparisons. There are several studies that have been done, of note especially by Laprade, which showed that these are very sensitive, and with varying degrees of joint space widening, you can actually predict whether a patient is an isolated ligamentous injury or combined injuries. Then we can also do CT scans, but these are generally done for characterization of periarticular fractures. MRI is the gold standard for soft tissue injuries, and nowadays with the newer technology where you have the 3 Tesla scans that have better and higher resolutions, it has made a diagnosis of these injuries easier. And there's also an issue of fixation, external fixation before doing your MRI scans. So sometimes when you use your external fixator, Hello?
Yes, hello, you can go ahead.
Yes, so ideally you should do your MRI before hardware placement, but if you have to put an external fixator, make sure that you use an MRI compatible external fixator, even though the image quality still with the compatible external fixators is not as good as the scans done before hardware placement. Then this is just an image showing the normal anterior cruciate ligament here, which is nice and taut. Then this one is a mid substance here, and then in this diagram you can't appreciate the anterior cruciate ligament. Then arthrography has largely been replaced by MRI, but it can be used with in combination with a CT scan in patients where MRI is contraindicated. For example, patients with pacemakers in the heart. Then arthroscopy is both diagnostic and interventional, but usually this is done at the time of surgery, where you now actually want to repair, not purely as a diagnostic test. But sometimes it may be contraindicated acutely, where you have capsular tears. It can result in fluid extravasation and compartment syndrome. Then when your patient comes later on, you can do the standing images, the 45-degree standing image, which is more sensitive for arthropathy of the tibiofemoral joint, and you can also do the sunrise and merchant views to view the patellofemoral joint. Then there are several classification systems. One of them is the Kennedy classification, which is mainly directional, with the anterior dislocation being more common, about 30 to 50%. And then the rotational dislocation is usually posterolateral. That's the one that gives you the dimple sign, where you have buttonholing of your medial femoral chondra through the capsule. Then the most common use is the Schenck classification, which basically divides the injuries from knee dislocation 1 to knee dislocation 5. Sometimes there is associated circulatory, which is noted by a C, or neurovascular injury. So those are the injuries. You can take a look at the table later on. I think at this point, I would hand over to Mr. Nube for continuation of the second part of the presentation, which is treatment.
Okay, thank you, Casper, for the nice talk, quite comprehensive, and you stuck to time. So now I'll take the opportunity to introduce our invited guests. We have Dr. Nico Chauke from South Africa. He did his medical training at the University of Limpopo, which is formerly known as the Medunsa. So he's an orthopedic surgeon at Chris Hani Baragwanath Academic Hospital, and he's also an associate lecturer at the University of Witwatersrand. He did his knee fellowship with Prof. Makabotha, and he also did a shoulder fellowship with Prof. Aiden. Both of them are in Johannesburg. He's also done a shoulder fellowship in France with Prof. Laurent Lafosse at the Alps Institute. So welcome, Dr. Chauke. Thank you for joining us here in Zimbabwe. The second panelist is Dr. Kieran McGarvey, all the way from the UK. He did his medical training at Cambridge University and his postgraduate orthopedic training at Guy's, King's and St. Thomas Hospitals in London. He did his knee fellowship with Professor Pontifera in Joburg and Mr. Tim Spalding in the UK. Kieran also did the trauma fellowship at the John Radcliffe Trauma Unit in Oxford. He is the match day doctor for a prominent rugby club in London. He's also a great guy, but he's an average golfer. So I'll hand over to Kieran now to present on the treatment.
Thanks, Thando. Thank you very much for inviting me. Very good to be joining you here from London. That was a great talk. Well done, Casper. So I have a case who I saw right at the beginning of lockdown here in the UK. I'm going to share my screen and go through that case. And hopefully my screen is coming up now. Can everyone see that screen? We can see that?
Yes, sir.
Yes.
Okay. So about 2 weeks into lockdown in the UK, everyone was terrified. Everyone wanted to stay at home. No one wanted to go out. But this lady took her dog for a walk and was knocked over by another dog. She came into the department with a normal neurovascular exam, including normal ABPI. She was of normal weight and normal health otherwise. Her range of motion was 0 to 100, so she was missing 5 degrees of hyperextension seen on the other side. Clinically, she had a grade 2 PCL, a grade 2 Ligament, and a grade 3 MCL. So her x-rays were largely unremarkable. There wasn't too much to see on those. But we got an MRI scan. These are the coronal T2 weighted images. And on the left-hand side, you can see that the MCL here has been completely torn from its femoral insertion. And that explains the grade 3 injury and the large associated soft tissue edema that she had on that side. You can see also some evidence of contusion in the lateral femoral condyle consistent with a valgus injury. Looking across to the other side, on the lateral side of the joint, popliteal tendon was intact, and on another scan, other slices, you could trace that popliteal tendon coming all the way up into its insertion in the popliteal fossa, so that was intact. And looking at the LCL and the biceps insertion onto the fibula, that was intact. And again, on other slices, we could trace the insertion of the LCL from the lateral epicondyle down to the fibula. So consistent with the clinical exam, she had a normal lateral side, but she had a grade 3 MCL. Onto the sagittal slices. So this is the lateral compartment. And here you can see the pathognomonic double anterior horn sign, suggesting a bucket handle tear of the lateral meniscus. Consistent with that, you can see a much lower volume of meniscus in the posterior horn. And coming towards the notch on this sagittal slice, you can see the lateral meniscus within the notch. So a bucket handle tear of the lateral meniscus. And then as we go further into the notch, the PCL. So here the PCL thickened, edematous, lots of high signal within it. And its tibial insertion, you can see that that insertion has gone. So amazing that it's only a grade 2. There must have been some fibers intact somewhere. But so she's definitely got a PCL injury. And then just as you showed on those, Casper, on those pictures earlier, here's the ACL. ACL, some tissue preserved near its tibial stump, but no evidence of any ACL tissue running proximally. So, Thando, do you want to put some questions to the group, or do you want me to talk about how we approach this?
Yeah, we saw from the physical examination that you compared to the opposite knee, and that's good because the normal side is for hyperextension, and the abnormal side is a straight knee, which would actually fool someone and think that's not a locked knee. So actually, that's a locked knee, and we can see from the MRI, which explains the locked knee. So I think that's one point which registrars need to be quite aware of. I'm surprised that your patient was not an obese patient. I mean, we often see the obese ones having the low energy forms. Can you just tell us about the demographics of your patients with multi-ligament knee injuries?
So I would say probably 80% to 90% are young males. Our hospital is quite close to a trampoline park, and we seem to get lots of guys who come off trampolines. So the majority are young sporting, and usually male. I would say about once a year, maybe more than that, we get a high BMI elderly female patient, usually in their late 40s, early 50s, BMI 35 or above. In fact, my very first on call as a consultant, I had a lady who was partially sighted, deaf, ultra high BMI, had fallen off a chair at home, and she came in with a dimple sign on the medial side, a buttoned-hold medial femoral condyle, an irreducible knee dislocation. So I remember those cases well. I think we all do remember the high BMI ones, but probably not much more than about once a year we see a patient like that.
Dr. Chow, can you...
The reason it's important to recognize is to know that it happens in these patients, because often these patients don't come in with a frank dislocation. They come in with a painful knee, and they come in with a big painful knee. And they're difficult to examine because of their size, and they often get an X-ray which looks pretty benign. And so the key thing is to be aware that it can happen to these patients. That's the reason why it's a significant injury is one to be aware of.
Thanks. Dr. Chow, the demographics of your multi-ligament knee injuries in Johannesburg, do you see the same thing as Kieran?
Good morning, and thanks, Thando, for inviting me from South Africa. So I would say maybe the demographic in our side might be different, because I just recently reviewed the cases that we had for the past, say, 18 months. Majority of cases that we have are females with KD 3L, most of them, and with high BMI. And most of them, they usually fall during the AGLS. I mean, we get less, we've been seeing, I would say around 30% will be MBA, but 45% will be from a fall. And these are the high BMI patients. Even recently during the lockdown, I think we had already seen, I think, 4 patients who underwent vascular surgery. True, they didn't have anything done. So I would say maybe the demographic will be different compared to what we have that side. And most of them is usually one leg. We have cases where we have bilateral, but these are very rare, where you get patient with a bilateral knee dislocation. In terms of the age-wise, usually the range will be 20 to 64. I think so the patient that we have in our setting.
Okay. You do mention vascular injuries. What are your indications for doing CT angiograms? Do you do them routinely or in specific patients?
So now we do the CT angio routinely in all the patients, whether they have hard or soft sign. So always test the CT angio. But I think it's much easier to look after those patients because you free the hands of the staff from doing the 2-hourly monitoring. So CT angio in our setting is routine now.
And patients who come with frank knee dislocations, after you reduce them, what's your preferred method of immobilization, splinting of the knee?
So if you look at the immobilization, it's still a bit controversial, but in our setting, what I've decided now is to immobilize them with a simple back slap overnight, and I'll review the patient myself to decide whether we should do X-fix or not. So personally, I don't prefer the X-fix because I think the placement of the X-fix overnight or by the on-call team, somehow the pins are not well positioned. And I've seen a lot of pin tech sepsis coming back to our clinic, which delays the surgical intervention in those cases. And patient with X-fix, usually we have a fight with the radiology. If you request the MRI scan, they always give you complaint. So my preferred method is back slap overnight, and they will review the following day whether we can use the PCL brace or just the normal brace.
Okay, thank you. Kieran, I think you can proceed with the case.
So, well, in terms of the management of this case, we had a really difficult discussion with this lady because my preference was to offer her surgery. I felt that the bucket handle tear needed to be addressed, and that while she was in theatre having the bucket handle tear addressed, we should proceed to stabilize the knee. Unfortunately, she is terrified and remains terrified of surgery and her risk of catching COVID. And so she was really keen to pursue non-operative treatment. And in the end, we came to an agreement that we would try and brace her knee in the acute setting and hope for healing of the PCL and MCL. And then at 6 to 8 weeks, reassess. And at that stage, address her lateral meniscus. I have used down bracing to downgrade MCL and PCL injuries previously. And so that's not an alien concept. And I think with the new braces, the PCL dynamic braces, then they are very effective at downgrading your PCL at least one grade. And we know that MCLs have a good capacity for healing. So the agreement for this lady was that we would brace her with a dynamic PCL brace, initially at range 30 to 60, then 10 to 90, and then full range of motion at 2 weekly intervals, hoping that we see healing of the MCL, downgrading of her PCL to a grade 1. And given her requirements, I didn't expect that she would require an ACL eventually at all because she's not involved in pivoting sports. And therefore, the only surgery that she will need, hopefully, at the end of the lockdown period when she's brave enough to have surgery, will be a resection of her lateral meniscus. So the braces that are available in terms of dynamic PCL splinting, there's a brace by a company called Medial, called the 4S PCL brace. And that applies a consistent force in anterior translation. And there is another brace by a company called Osser, which provides dynamic force. So it will, as you bend the knee, the hamstrings will tend to create a posterior translation force. And so the Osser rebound brace will create an increasing force with increasing degrees of flexion to counteract that. But I should stress that in almost all of the circumstances presented with this injury, I would recommend early surgery, so surgery between 2 to 3 weeks post-injury.
Okay. I see you did an MRI on this case. Do do MRIs immediately for all your cases, or what's the timing for your MRIs?
So these patients come to me in two ways. Either they come in through A&E overnight and they're seen the next day, in which case we get an early inpatient MRI scan, or they come to my acute knee clinic. And those are usually ones where the A&E department haven't quite appreciated the extent of the injury. I want to get an MRI scan as soon as possible after I see these patients. So in all patients, I'm getting an MRI scan. Our hospital is pretty good in responding to requests from our knee team to get these done, and usually we can get them done within 24 hours.
Okay, so for the chronic cases, we often schedule their surgery. We do it in an elective manner. With the COVID-19 disease, we are sort of deferring the elective cases, and therefore we're going to have quite a number of patients who've got MRIs done, but their surgery is going to be deferred. So an MRI done 2 months prior, 3 months, 6 months prior, would it still be of value at the time that you plan surgery, or do you envisage the need of repeating MRIs?
I think you want an up-to-date MRI scan. So if this is an acute presentation and I'm planning early surgery, that early MRI scan is enough. If you are dealing with particularly the PCL and MCL injuries, as I said before, they have capacity for healing. And so if they have been braced effectively, then I think you want to see ideally an MRI scan closer to the time of surgery, but more useful closer to the time of surgery will be some stress views. And your Casper mentioned doing those under fluoroscopy. In the acute cases, after about 48 hours, and definitely in the elective cases, you can do those in the radiology department. And I would recommend, if you can, doing those for two reasons. One, with fluoroscopy in theatre, the position of your C-arm in terms of its magnification can give you a false impression of your side-to-side differences. So if you don't position that C-arm exactly the same for the left and the right knee, then the joint space will appear different simply because of magnification. Secondly, it gives you limited time to plan if you're doing it fluoroscopically. If you do this in the radiology department, then you know exactly what you're going to do before you go to theatre. So I'd recommend trying to do it, certainly in the elective cases, pre-op. And then with the patient awake, they tolerate it.
Dr. Chauke, I've worked with you in Joburg, and we have the issue of delays in getting surgery done for patients. From the time from MRIs to the time of surgery. What's your take on the value of an MRI result, which is quite old?
Yeah, thanks, Tando. I think that the MRI for me, I think it's very useful in the acute setting, especially for the PCL injuries. I think later on with the PCL injuries, sometimes very difficult to decide whether it's just the legs or heel PCL. I think that's where now the use of stress X-ray is very valuable. But in our setting, we can't even get a stress X-ray, so that's why we use the fluoroscope. So if I get an acute knee injuries now, usually it takes like 2 to 6 weeks to get MRI scan inside the patient. And then after that, that's when we plan for surgery. So I think maybe the setting here might be different from a Sierra setting. Maybe in that case, I can ask him a question, because like in his case, let's say you had opportunity to operate this patient with a bucket and we'll discuss. Will you consider doing everything at once, or just go and fix the bucket handle first and then stage the ligament injuries?
I think with this lady, I probably would have done everything at once. She's 50, so the bucket handle repair, the biology is not time's not on her side in terms of that repair working, but certainly if it looked repairable, I would have tried, and I would have also repaired I would have reconstructed both her PCL and her MCL. Her ACL, I would have done if I had time. The ACL is the one that I will leave to a staged procedure if I need to. So if I'm running out of tourniquet time, the ACL is the one that I will defer. So start extra-articular, do the PCL, and if you're running out of time, then defer the ACL.
So would you have repaired or reconstructed the MCL?
Yeah, in this one, yeah, I would do. I use the ipsilateral semitendinosus. I'll leave it attached on the tibial side. There's a technique by Martin Lind, which describes a nice technique for doing this, and I would reconstruct it using her ipsilateral hamstring tendon.
And then your graft options for the PCL?
So in this age group, I would probably have used Lars synthetic. The results for Lars PCL are much better than the results of Lars synthetic ACL. The jig system is actually very easy to use. It delivers the graft quite nicely around the killer turn. It also allows you for outside-in drilling on the femoral side, so you can make sure you don't have any convergence with your MCL femoral tunnel. And it gives you a pretty rigid fixation, especially in these patients in the current environment where their access to physiotherapy because of lockdown may not be so easy. So I was planning a Lars synthetic PCL with ipsilateral hamstrings, and had I got to do her ACL, I would have used her quadriceps tendon.
Okay. So for the chronic cases, I think it's important for consenting the patients pre-op that you mentioned that you may harvest contralateral hamstrings. Yeah, I think that's one tip for the registrars. When you get pre-op consent, don't forget to consent the patient for contralateral harvesting. Now, with management of your grafts in theatre, do you soak them in antibiotics?
Yes, I do. Vancomycin, 500 milligrams, 100 mils.
Dr. Chauke?
I only do it when I'm doing multiligament and only for allograft. For autograft, I don't routinely use.
Okay. Sharon, one more case. You still have one more case for us?
Yeah, I do. The point of PCL graft choices, synthetic again was a reasonably unique decision for a lady in her 50s, relatively low demand, an acute case with limited access to physio post-op. For my a younger patient, for a chronic patient, I'd be looking to use allograft, probably a tendo Achilles with a bone block. You need a big amount of tissue to reconstruct a PCL. I think the hamstrings are too small and it's too unreliable from the same patient. So I normally use allograft for my PCLs in the young patient. I do have some other cases. This is this is one of the trampoline victims. So he's a 24-year-old male. He has been on the trampoline next to the hospital. He's come off the trampoline and describes what sounds like a hyperextension mechanism. He's otherwise well. He works in an admin job and wants to return to playing football and ideally jumping on trampolines. So his examination, as always, the first priority is to check that he's neurovascularly intact. He was seen overnight by a registrar and he was added to the trauma list the following morning as a tibial plateau fracture. These were his x-rays. The registrar had spotted the depression on the lateral tibial plateau here. And he got a CT scan which confirmed the injury, the depression on the lateral side and anterior, consistent with the hyperextension mechanism. But when he was taken into theatre, his back slab was taken off. With all tibial plateau fractures, we do an EUA. he had this. So grade 3 opening of his MCL, grade 3 posterior translation of the tibia, and he also had a grade 3 Lachman. So this, in fact, was a knee dislocation with associated tibial plateau fracture, grade 3 MCL, grade 3 PCL, and ACL. So now we're in a difficult spot. He's not consented for any ligament reconstruction. He's consented for tibial plateau fracture fixation. So again, Sandra, do you want to put that to any questions, or does anybody else have any questions about that case?
I think for the sake of time, you can proceed with the case.
Right. Okay. So this was a consent issue. So the learning point in this case actually was this little piece here. So that probably was indicative of a cruciate avulsion type injury, which hadn't been spotted overnight before he was added to the list. So in the end, he had tibial plateau fracture fixation, some raft elevation off that piece, some raft screws, and a lateral plate. And again, out of not out of choice, but out of necessity, we were forced to brace him. So again, he went into one of our dynamic PCL braces for 6 weeks while the fracture healed, hoping to downgrade his PCL, hoping to achieve healing of his PCL, and hopefully we'll see him at the end of lockdown. And if PCL and MCL have healed, then hopefully we'll get away with just an isolated ACL reconstruction. Obviously, if the other two ligaments haven't healed, then he'll get a PCL reconstruction. That'll be an allograft PCL. We'll use his ipsilateral hamstrings for the medial side, and probably a quads tendon for his ACL.
Interesting case. Lots of pitfalls. I think, it's just a reminder of being vigilant when you deal with these cases. I don't know if there's anybody in the audience who's got a question for the panelists. Okay, okay, Gilbert, go ahead.
Okay, thank you, Dr. Tandu. I just wanted to make a short comment on nerve palsy before I ask my question to Dr. McGavin. Maybe for the benefit of registrars, the anatomic status of the nerve is always important each time you are faced with a case of multiligamentous knee injury. And also, you always need to try and do the Tinel sign, because it has been shown to have a role. If the Tinel sign is positive when you assess your nerve, your nerve injury, then the likelihood of recovery is there. But my question now comes to Dr. McGavin as to the choice of management, whether to do a nerve graft. We know there is peroneal nerve palsy usually associated with these injuries, but when do you decide to do a nerve graft versus a posterior tibialis to a tibialis anterior transfer?
Thank you very much for the question. So I think the evidence is that nerve grafts tend to do well over a relatively short distance, maybe about 6 centimeters. But there's some evidence in multi-ligament knee injuries that the zone of injury of the nerve is actually much greater, and it's probably up to 10 or 12 centimeters. So I think the move in general is away from grafting and more towards getting this patient for a tendon transfer if there's been no evidence for recovery. So if there is a lateral-sided injury, I'm always going to dissect out the nerve. If I find the nerve is in continuity, I make sure I do a good neurolysis. If the nerve is cut, then I tag it for the benefit of the peripheral nerve injury surgeons who might come later. And then I get some nerve conduction studies that are around about 3 weeks. If the patient hasn't shown any signs of recovery at 3 months, then they get another set of nerve conduction tests. And at that stage, then I think the move now is toward tendon transfer rather than nerve grafting. But at this point, the patient's care has been transferred to a nerve injury specialist, and that's not something I personally would do.
Thanks, Kieran. Yeah, I'm in agreement with your approach. The zone of injury is often quite wide, even up to 20 centimeters. So nerve grafts often don't do well for the common peroneal nerve. And as such, neurolysis or just a posterior tibial transfer at 6 months or at a year would be the ideal management for those patients. We can see that we're out of time, but just one cheeky question for Dr. Chauke. I know you do robotic knee surgery, and the pitfalls in multiligaments knee reconstruction, challenges with tunnel positioning, as well as tunnel convergence. Do you see a role for the robot in assisting with your tunnel positioning?
My answer is no. I think if you look at the multi-ligament reconstruction, you need to look at the patient that you have. So I look at a patient, the soft tissue, I'll say patient with high BMI. Those are the patients at risk of tunnel convergence, multi-ligament reconstruction. A patient with a small bone, sometimes you find the patient have a small notch or the small distal femur. Those are the patient at risk. So I don't think a robot will make any difference in these cases. I think you'll have to plan your surgery properly. So another thing that's a big concern is anatomic reconstruction, because I know most people pushes for anatomic reconstruction. So if you do anatomic reconstruction, the chances of tunnel convergence is very high, especially if you have a high BMI and a small distal femur. With a BMI, it's difficult to flex the knee, so the tunnel will collapse easily. With a small diameter femur, you can't do a double bundle reconstruction if you prefer to do a double bundle PCL. And if you have an MCL where you need to do your 2 tunnel for your popliteal oblique and the MCL on the femur, you can't do it in a small femur. So if you want to do anatomical reconstruction, it's a bit of a challenge. What you need to know, for me, I think the paper that I've seen is the one by Gilbert and Watson, where you need to make sure you know the direction of the angles, the double angle that you need to follow. I think that's the best paper to use at the moment.
Okay. Gilbert Moatse, the one whom Dr. Chauke is referring to, is a knee surgeon. He's from Botswana. He's a new kid on the block, and he's working the world of knee surgery. So I mean that would be a word of encouragement that even if you are in sub-Saharan Africa, there is a lot that you guys can do. There's lots of talent here, and so anybody who's interested in knee surgery, I would really encourage that you pursue a fellowship and hook up with senior colleagues such as Dr. Makabi and Dr. Chauke. Without further ado, I want to thank the panelists for their contributions. We really appreciate your attendance of this webinar, and I will hand over to Mr. Megeza. Thank you.
Thank you very much, Dr. Tando. Thank you, Dr. McGarvey. Thank you, Dr. Chauke. It was a pleasure having you around. I hope you will join us in the future when we need you around. And to everybody, it's a good day. Bye.
Thank you. Bye.
Thank you very much. Thanks for the invitation. Thanks, Ando.